Yes, please.
Fantastic. And maybe I can start with you. Partnerships in global health have been discussed for decades, given the complexity of the challenges that we face and the fact that, really no one sector or organization has all the skill sets and relationships needed to be successful. So what's truly unique about this area of partnerships that is critical for us to understand as we talk about AI in global health?
Thank you, Natasha, and it's a real pleasure to be here with all of you. And I don't know if it's truly unique, but the first condition for me, at least what I understand best, is it needs to be a public-private partnership. If you want to have an impact on a health system in countries, at least where public health systems are still the predominant or important part of the health system, you need to have the government on board to integrate the solutions into the workflow or bring the solutions to scale. And that's not necessarily unique to AI partnerships. It's also by definition for digital health partnerships. But for AI specifically, I think it's important the government remains in a kind of a driver's seat to coordinate the different partners. Because if the solutions that are brought to the health system are not really corresponding to a need that exists in the country, a priority need that is defined by the health policymakers, they will never reach scale. If it's more solution-driven than needs-driven, the partnership will not get sustained at scale. We've seen that in many examples of the Broadband Commission report as well of the partnership. So maybe it's not unique, but it's really important. On the other hand, what is really important as well is that it has to be a multidisciplinary partnership, because not one partner, as you said in the beginning, Natasha, has enough bandwidth to handle all the questions around driving AI in health and care. So you need at least a partner from the tech side and from the health side, someone with the experience and expertise in data science, and someone with the expertise in health and health systems and global health. So obviously, other sector partners and disciplines are also welcome. And lastly, I think for a partnership to be successful in the field of AI in health, it has to be including the end users of the solution. If it's not centered around the needs of the people who will use it, and it's not thinking about the processes that will be developed or implemented to integrate the solution into the health and care provision, then the solution won't get the impact we aim for it. So I guess most of these elements are for me kind of unique, but there may be others that I'm missing. I would love to hear from my colleague panelists as well if I'm missing something.
Yeah, Marlies, maybe I'd love to invite you into the conversation, given Anne started with the critical role of governments, and that's a key area of focus as the World Bank endeavors to have an impact in low and middle income countries.
Thanks very much, Natasha and Anne. It's lovely to be on the panel this morning. I think that when it comes to AI and health, one of the challenges of the partnerships that I'd like to build on the excellent points that Anne has made is that there is mutual capacity building that needs to take place. In other words, the private sector partners are not necessarily used to building solutions in contexts where governments are both the providers of and the payers of the health system. In a context where the Ministry of Health appoints health staff, provides all the drugs, runs health facilities, that's a different setup than a private sector provider of health services. So the private sector providers of AI embedded solutions need to understand a different modality of delivering health services, and governments are still trying to understand the use and usefulness of scaled AI solutions in health. One of the main areas of focus that I think is important and that we've not yet focused on sufficiently is in the area of evidence for digital health. We come across resistance in some cases where, unfortunately, AI is seen as robots doing surgery, right? And we've really kind of sold this very high-end 21st century sci-fi type vision of what AI in health entails, right? Whereas I think there are many low-hanging fruit, places where AI can be used, but we need to work on that mutual understanding on both sides, on the private sector side and on the government side. And we're going to do so through case studies, through evidence, and not just selling technology, but selling answers to pernicious health problems. And I think, and that's one of the other things that is unique about partnerships in this space, is that we need to understand AI is not the end in and of itself, but the means to an end, right? We need to focus on transforming health systems, and we need to focus on health systems in a connected digital world. What does that look like? Where consumers demand and consumers want choice. We want to build patient-centric systems. All of that is, so it is partners getting to know each other in a context where the system itself is changing, right? And so it's a change within a change within a change. And I think that's part of what is unique and challenging, and why we haven't seen a wide implementation or scaled take-up of embedded AI solutions in health. We've seen case studies, we've seen small pilots, but it is still nascent. And I think there's a lot that all of us sitting around the table can do to collectively move the needle forward in a way that will give governments the confidence that their data are being protected, that this is not taking the power from their hands, but in fact, this is providing them with an expanded set of arrows in their quiver to solve the problems that they face on a daily basis. Thanks.
Brilliant points, Marlies. Sathi, I know this is a topic that you spend a lot of time thinking about, being an implementer on the ground and working with so many of the partners that Anne and Marlies mentioned. I'm curious how you've been thinking about this topic of partnerships in AI and global health, and how you specifically think about this point around capacity building that Marlies mentioned, which she mentioned how it had to be mutual on both sides.
Yeah, no, I totally agree. You know, our fundamental partner in the work we do is the Ministry of Health, you know, government hospitals that we work with, delivering solutions that incorporate AI and natural language processing. And I think there's a lot of work that needs to be done in helping people understand, you know, what AI is. It's a broad term, you know, what machine learning is, the difference between data science, AI, automation, vastly different things. And I think to the earlier points, one of the striking things about the requirements for partnerships with AI is the speed at which the domain is moving and the technology is moving. It's so fast compared to, you know, previous sort of fads that we've had in global health. And I think the danger with that is people are getting left behind. And when people get left behind, there's a risk of either shutting yourself off from the technology or wide-scale adopting the technology without understanding the underlying potential risks and benefits. So capacity building is essential, and we need to do it ASAP, I would say.
And in the beginning of your discussion on what's unique, you mentioned some of the new partners that need to be at the table, from tech to data science partners. I'm curious, have these been partners that have to date been on the sidelines in global health? And if so, how did you encourage these organizations to start engaging in this complex area of global health and collaborate with us in innovative public-private partnerships?
I don't know if they have been left at the sideline, but definitely not always been included. We've seen so many good, well-intended digital solutions fail because they didn't include the end user. It became almost a condition sine qua non for scale, that you have to include the end user's needs if you want to make your solution a successful enabler. Because I really cannot agree more with you, Marlies. All of the digital and AI-driven approaches are enablers to change our health systems and make them better. But I think the end users definitely have not always been considered. Other partners like governments have usually been considered in countries where they have a large role to play. But for example, we've seen in the Broadband Commission report many examples of where AI already has a massive impact in the field of health, and it's not limited to the field of clinical care only. It's covering areas from population health to R&D to develop and discover and develop drugs much faster and therapeutic options, to clinical care, but also to patient-facing solutions so that patients get the health and care where they need it, as close as possible to where they are. And lastly, to optimize health systems operations. And there, again, if you don't look at what the real needs are for a health system on the ground, even if they don't have a fully fledged digital health system, they may have very well needs that can be addressed with AI automation that are low-hanging fruits Marie-Lise was alluding to. Huh? So I think not forgetting them is really a condition for AI partnerships to be successful. And to build on Sati's point, which is also so crucial, that it's a risk for countries to be left behind if they don't invest in all the different elements they need to invest in, or even providers to be left behind. This risk is real. So low and middle income countries have most to gain from the AI revolution and the use of AI in their health system, but they also have the most to lose if they don't now invest in the 6 areas that you mentioned in the beginning, Natasha. They all have to think about, first and foremost, their people and workforce. If they forget to build that capability so that the people will understand the partnerships in to drive AI solutions in health and be able to use them properly, they have to invest in the infrastructure and the data. It's not that there's not enough data, but you need data that can be used by these massive computational powers we now have. So it has to be streamlined and interoperable and all the things we know. You need to have governance systems. If there is no regulations to keep the people safe and their data private, it's going to be a messy situation in the country. So that's absolutely key. And this needs-driven, human-centric design, together with identifying the processes and the sustainable business models, are only 5 of the 6 of the other investments countries have to look at. And if they don't do it now, they risk to be left behind. And I think this is a real strong and important message for all governments to transform those health systems from reactive to becoming predictive. We need them to invest in the right.
No, those are great points. And I particularly love this theme that keeps emerging across all of your reflections around being needs-driven and taking more of a human-centered design approach so that end users who have not always been considered can be at the table and helping to drive more appropriate solutions. Sati, this is a place where I feel like implementers and NGOs have a particularly critical role to play. And I'm wondering if you could describe one of the most impactful partnerships that you've developed in global health that really leverages AI, and how you really thought about kind of engaging end users and other partners.
Yeah, absolutely. And, you know, I should say at the outset, we're not a technology firm. You know, we're a maternal and child health focused nonprofit organization. And we had a digital problem, right? We had moms using our digital health platform, texting in, asking us thousands and thousands of questions a day. And we realized, well, if we don't find a responsible way to triage those questions effectively, we're not going to be able to respond to the moms and identify those that need support urgently. And we recognize that one of the approaches we could use is by looking at AI, looking at natural language processing. And as a non-technical startup, we sort of hacked our way to a semi-solution. But one of the critical partnerships that helped us get from point A to, frankly, point Z was a partnership with RippleWorks, which paired us with talent in Silicon Valley, pro bono support to get us to optimize our platform, optimize our use of machine learning, run the appropriate tests, consider risks we hadn't previously appreciated that were important, that had been noted in the private sector. And that sort of technology pairing was critical. So it's not that is a sort of combination of a boots on the ground outfit like Jacaranda working with expertise in Silicon Valley that didn't really understand the end user, but certainly understood the use of technology in a certain paradigm, and that helped us improve our approach. So I think there's an ecosystem of players out there, fantastic technology providers, and then folks who actually understand the end user perspective. And by bringing them together, you can certainly achieve more. There's plenty of room for synergy. So that's how we've grown.
Marlies, I see you're nodding your head in agreement. I'm curious if that's a similar approach that you've taken as you've embarked on partnerships in this space, and perhaps using an example, you can share the kinds of challenges you encountered when you were identifying, engaging, and sustaining partnerships.
We don't hear you, Marlies.
I was nodding when Sathi was speaking, thanks, Anne, because it very much echoes our experience as well. You know, I think there's always a balance to be found between building the perfect versus, in a more pragmatic way, finding some quick wins, right? And I think that what we've tried to do with AI, as I said earlier, is start with the highest hanging fruit, right? The clinical decision support system that will take over the role of the physician. Whereas I think now there's much more of a consensus that we're really looking at AI providing augmented decision making, right? So just assisting a community health worker, assisting a 1 or 2 person health post or primary healthcare center make wiser decisions, right? It's something as basic as sending our community health workers, the largest health workforce in Africa, sending them to places and to households that we can predict will have low levels of immunization, that will have challenging health situations, looking not just at their health data, but at other social sector data, education data, social grant data that are available, to be able to say, let me use the workforce that I have available in a micro-targeting, micro-planning kind of way, much more effectively than what I've done before. I think that's something that every country that has a village or community health worker workforce with some kind of mHealth app, which most of them do, can roll out a solution like that relatively quickly and easily, right? I think some of the challenges that we've encountered along the way are really in 3 areas. It is to do with this issue of capacity and expectation management. It is also to do with the immense fragmentation, right? Some of the investments the bank is now making is in combining different individual community health worker apps into a joint integrated app that would link directly with the district health information system, which is the health information system used by many countries. I think a second challenge, which is an old challenge, it's not an AI challenge, and that's to do with data. We have, and I think we all know this, we have islands of fragmented data without unique identifiers sitting in places that are not always well governed, and there's no or very poor data stewardship practices in place at the national ministry. I think this is a critical challenge, and until we can solve this, we're not going to reap the potential or realize the potential of AI in health. As partners, we all have to work on the 20-year-old challenge of bringing all the health data together, because although 30% of the world's data in the global data sphere might be health data, it is islands of small bits, lots of islands of small bits of data. It's not all integrated. It's not interoperable. We can't link a person across time, even between facilities, right? If I move from facility 1 to facility 2 in many countries, I'm counted as lost to follow up in facility 1 and a new patient in facility 2. Whereas that should not be the case. We should be able to at least track patients over time across clinics and across disease conditions, because very few people have only one disease burden, right? Only one cause of illness or lack of well-being. So as partners, to me, that is a critical area of partnership, right? And there is this interesting global debate about, do we keep building the data systems, and we've built health information systems for 2-3 decades now, or do I move into applying and using that health data? I think we need a bit of both, but we cannot forget that one of our most pernicious challenges is around data and bringing data together in an interoperable way. Many countries can't provide a master list of health facilities. I know of several countries that have 3-4 master lists of health facilities, right? A master list of health providers, codings for disease conditions and codings for pharmaceutical and non-pharmaceutical interventions to address those disease conditions, a focus on preventative care. All these things and all these data and the way we code and categorize these data all need to come together if we want to reap some of the higher level benefits of AI in health. I would say that the other challenge that I think is worth pointing out is that we still have to do a lot of work in defining sustainable private-public partnerships in the digital health space, right? On the one hand, there's a strong push for open data in health with privacy and consent provisions and non-identifiable data obviously taken into account. There's a strong push for open software, open source software. What does the sustainable business model look like for a technology company that wants to invest in building a solution, and at the end of the day, they have salaries to pay, they're in it to do good, but also to make money, right? What do we figure out what those business models look like? And I think this is where many of the technology investments are still struggling, is in how do we define mutually beneficial private-public partnerships that neither locks a government in to a single vendor ad infinitum, but that also provides sustainable income for a private sector company. Bringing those together, I think, is going to be critical to be successful. And then I think in the area, the bank together with other partners is involved in a digital health applied leadership program, because I think we have to help governments to think through how digital health and their digital health system, all the parts of the digital health system, knowing we're not in a greenfield development, knowing that there are many digital health solutions already in play, we have to give governments the assessment tools, the skills, and the knowledge and the know-how to bring all these pieces together, right? And knowing that we can't stop every digital health intervention already in play, how do we bring these together in a pragmatic way that where the perfect doesn't sacrifice the pragmatic, but where we keep privacy and consent in mind, and we have excellent data governance and stewardship, which is the only way we'll be successful in building trust of not just governments, but citizens in these digital solutions. Thanks.
Those are great points. I heard a lot about this point around data. How do we really improve the islands of unique data that currently exist, and thinking both about the building of data systems and applying the data. I heard a lot about the sustainable business models behind it. And then I heard about this digital health applied leadership programs and some of the capacity building that we can do with governments. I want to go back to the first point you mentioned around data, because I think that is a particularly challenging point, because we know that data is so critical to the success of AI-driven solutions, and without appropriate representative data, we can create more problems than we had to begin with. This is a challenge that we haven't even quite figured out in high-income countries. I'm curious if there are examples of countries or programs that have done this well, that we can point to as exemplars that we can learn from. And maybe I can start with Anne, because I know that's a topic you've thought a bit about as well.
Thank you, Natasha. Yeah, I think I agree really very much with you, Marie-Lise. It's there's a multitude and quantity of data available, but not really usable yet. And maybe in some cases it's not. It will require too big of an investment to make them interoperable, to make them usable for machine learning, and maybe we could do it in a different way. But it's true that we should get there with the data we already have instead of hoping to always get more and more data. We need to get the minimal essential data to answer certain questions. I think the answer to your question, Natasha, I will come to it in the end. But one example of how we see that you need to build these new types of partnerships for AI in health is that you can never have everything in one organization. So I think data collaboratives is also a way forward. So data collaboratives to really exploit together what are the exact problems we want to address, what are the questions in the field of XYZ we want to address with data, and then we bring the necessary data together to develop those AI solutions that would address the question, and then validate the solution on local data that can remain in situ potentially, or validate it in comparable settings so that it can be trustfully used in another country. And this is what we have set out to do together with Microsoft Philanthropies. We really went to, the president of Microsoft has a new initiative on open data initiative called, and we went to bring together the data from several partners into one big pool, which we are still building on, and we will work together with Natasha in Accenture and her teams, and where we want to look at how can we really help decision makers in countries. We don't want to go for the clinical care necessarily, but decision makers, policy makers. How can we develop AI-driven tools that make their decisions real-time based, real-time data-based or evidence-based instead of opinion-based or resource-based, because currently resources are allocated kind of blindly in many cases. And if AI-driven solutions can help decision makers to stratify their populations or better allocate the necessary expertise in different areas, this will definitely transform the way health and care can be delivered. So with that data collaborative, where we already have data from several both private and public sources, we aim to increase that pool, and we use the expertise of the data scientists of Microsoft Philanthropies, which are the data scientists of Microsoft as well, to then develop those tools. And it's a neutral group of experts, global experts, both in population health, in digital, in data science, in policy making, from different angles, are defining the questions that need to be addressed by that data collaborative. So I think this kind of partnerships is also a way forward, because it will jumpstart some countries who don't necessarily have the resources to build the data sets, and who can have these solutions available if they have been validated in similar settings. So I feel that's really a way forward as well. And lastly, the example of countries that have it, I think we always fall back to our classic example of the best digitized health system, or the first best digitized health system, which was Estonia. But I think in the field of AI, I guess Finland is now spanning the ground, but I don't know really what exactly, if they have it all figured out, but they have it figured out pretty well, I feel.
Marlies, I see you nodding your head. I'm curious if you've had any experience with some of those countries, if there's other exemplars that you might point to from which we could learn.
Yeah, I think there are a few examples. I definitely list Ethiopia. I think they have an incredible and long-standing focus on building the health information system, creating unique identifiers and electronic health records. And they have a very strong government-wide focus on coordinating all the information, not just health information, but education and other information as well. So I think Ethiopia is a country that's particularly strong in that regard. I'd also mention Saudi Arabia, that I think has a very strong digital health system, and then I think there are countries that are making particular investments and progress in using the existing data to help transform their programs, even though using machine learning as once-off analytics and not yet embedded, operationalized machine learning kind of embedded within implementation. So we have examples from Pakistan, we have examples from India of countries that have used machine learning to do, clustering and other analyses to really micro-target, define populations and end users in a much more sophisticated way than in the past, and to use that data to segment and micro-target and provide differentiated care to different kinds of audiences and different beneficiaries, different patients. So beyond the typical male, female, urban, rural, by age group, which is typically how we divide our clients, right? But if we think about our clients in a much more nuanced way, in terms of education level, in terms of type of employment, in terms of, sexual reproductive health seeking behavior. There are so many different data sources that we can already use to develop new kinds of typologies for how we're thinking about clients. And we can do all of that with the existing data that are available. And there are more and more case studies that have now been published, even in academic journals, of countries that have done that with success. Decreasing, polio, for example, in Pakistan is probably one of the big success stories in that regard. And that didn't require this fully interoperable EHR with kind of live data ingesting and live data analysis, kind of what I would call embedded machine learning, embedded AI with all the data engineering and data ingestion and everything that goes with that. This is using the data that are available, linking the data across sources from surveillance data to routine data to education sector data to social grant data, and using that as a basis to make recommendations to programs. And to me, that is the low-hanging fruit, right? And yes, we need to strive for those higher level solutions and the more operationalized AI. But there are some low-hanging fruit things that we can do now that I think are important to show applicability and to show the relevance to countries. And that will also give them the confidence and build skills internally within the organization, right? To understand what is clustering, what is supervised learning, what do we mean by data ingestion, how do we need to change our system? Because I don't think it's that countries are, or our experience in talking with countries is that it's not that countries are reluctant in using AI, it's that countries don't know where to start, right? It feels so far away that if you can just start with a few quick wins and you can say, here's a roadmap for your country looking at, and we think of maturity of a digital health system in terms of the maturity of the architecture and the data. So the first A, the maturity of the digital health applications and interventions and how they're prioritized and scaled. So the second A is on applications. And then maturity in terms of analytics, the extent to which existing data, all the kinds of health data that tells us about people's health and well-being, how those data are being used. And I think that if countries can see their health systems in the context of those 3 A's of a maturity model, then they can move to saying, for my country, it makes sense to focus on analytics. We're going to focus on the architecture. We're going to focus on reducing the 239 mobile health applications that Ethiopia discovered, of which the government in their own government facilities only knew of 39%, right? If we can just reduce that kind of fragmentation, that is a big win already, although it's not the headline robot does surgery, which is how it's the imagery around how we visualize AI, right? I'm sorry, it's always a robot with a scalpel in his hand. I even am giving him a gender, right? But that's just, and I think we need to move away from that imagery to a more tangible, feasible, practical reality. And that's how we're going to build an army of champions that are going to say, yes, I want this, I need this. And if countries demand it, development partners and private sector partners will provide it. But it comes with the demand, and we're not going to create the demand by making it feel like something foreign. So I think if we can address that, we will incrementally be successful.
Brilliant points, Marlies. I'm curious, Sathi, given your experience being on the ground in Kenya, have you seen like a similar challenge with the government trying to engage, that they want to, but they don't know where to get started? Any thoughts or reflections from your experience that you'd like to share?
Yeah, I mean, I would second the point on, there's a tendency to set the goals astronomical. Even with the amount of data required, you actually don't need that much data. I think a lot of countries have sufficient data and don't do, as much analysis as they probably should be doing with the data they have. Let's set aside machine learning. So there's always an over-reliance on collecting more data and repetitive data that someone else has collected before. I think actually the lowest hanging fruit, or one of the lowest hanging fruits, but with potentially high impact, is on data quality and just triangulating data from different sources. I think as Marlies had mentioned, or Anne, it's like huge, right? Like 3 different spellings for a facility name, that's a machine learning problem, right?
Exactly.
Like very easy. And we actually use it and it's quite useful. I would want to throw in 2 maybe counterpoints. One on data collectives. So as a team working on natural language processing, we would value and really love to see natural language data sets that are in local languages, Swahili, community languages, etc. And that's not going to happen from an industrial giant like Google. It has to come led by the government or led by a consortium. However, as an implementer and an innovator, our competitive advantage is on the data we collect and the use of our data and how we use that data that we collect in partnership. And there's a natural sort of challenge there. If you are opening up data sets, you are negating the competitive advantage of those small fragmented firms that may have collected that data. And we don't have the answer to that. We need the open data sets, but we are reluctant as an organization to share. So that's unfortunate. And then the final counterpoint I would mention is, although as an organization, we work fundamentally as our core partner with the Ministry of Health, with the government, we need to start talking about data being owned by individuals and beneficiaries. Yeah. Health data should really be owned by the client and the patient. This is the wave of the future. It should not be the government that owns it. There's a huge ethical challenge with that, personal opinion. And I actually think that's an opportunity if you have individuals holding their own health records. And we can do this now with technology. We can do it now with phones in everyone's hands. Then you have this sort of leapfrog effect of being able to triangulate health records and health information. So I think we need sort of a mind shift in terms of how we think about who owns that data. And the rightful owner is the individual who's providing that data, frankly, and whose health data it is. So thought I'd throw those potentially semi-controversial points out there.
Not sure if they're truly controversial. I think they align with a lot of the great thinking that's happening right now around AI, data ownership, and could help to address a lot of the points we talked about earlier around better engaging the end user. If they are owners of their own data, there is an incentive to engage them in a way that they haven't quite been to date. And I'm curious, based on some of those points that Sathi just raised on the data collaborative and kind of this tension between kind of contributing data when that is part of your competitive advantage. How have you been thinking about that as you've been embarking to set up these data collaboratives, and any learnings that you can share based on that?
Yeah, in our data collaborative, we went with the condition that it's an open data collaborative with any output that would come out of it will be open source. There's no IP owner in the game. However, that being said, it is really hard to get partners joining the data collaborative if there cannot be any IP owner. For example, so we've seen that the challenge really.
And I think you're cutting in and out. Is that just me?
No, yeah, I was cut off a little bit, but yeah, I think we really want to have it as an open IP, every output that comes out of the data collaborative, but still there, the challenge was is to find partners who want to share their data. And maybe in the end, it is not necessary to bring all the data in the same cloud together. Maybe we can do it in a different way. That's what we are trying to achieve now. But it's very important for us as an organization and for Microsoft Philanthropies that the output of this data collaborative will be open and published open. So one of the other partnerships we have been running also before, for example, to develop the tool that uses images, skin images, to detect leprosy earlier. Leprosy is one of the oldest diseases known to man, and we want to eliminate it with the newest technology we have available. And in fact, we have developed this tool that is AI-driven to diagnose patients as early as possible as they have a suspect lesion. And in fact, the data you need for that and the output we use to describe it is already all open source and is now given to the leprosy community or the Global Partnership for Zero Leprosy. We think it's crucial if you try to address global health problems that it becomes accessible to everyone. It is not the same as two private companies joining the data collaborative. Then we have very big challenges to get access to the data. That's just the truth. It's very difficult. What you say, Sati, I cannot agree more.
Natasha, if I could maybe just add, because I take these points, but I do think that as with any challenge, a complex challenge, there is a common sense, mutually negotiated middle ground that we can find, right? And I think some of them has to do with managing expectations. Let me just put it that way. So for example, the World Bank, we work and have access to and are given sometimes data by governments for specific analyses, right? So we have data use agreements that defines, and sometimes even private sector companies work with us, right? We have data use agreements that defines for how long we have access to the data, what we will do once the data is, we do have access to the data, how we improve that data, what will we do with the data once the analysis and the analysis products have been completed, and will that data ever be publicly available as well? And so governments make these decisions when they engaged at the time of engagement. We have a very successful data collaboratives program where we have over 30 global private sector and local private sector companies that provide the World Bank with data, not all data, but some data. And I think that's the middle ground we have to strike when we talk about privacy and consent in health data. We need to talk about consent because privacy, I think, more and more is becoming impossible. Facebook tells us that with just 3 data points, they can basically identify and pinpoint any one of us. So, you know, we need to focus on how we build consent and the ownership of the data resting with the individual. Again, I agree with what Sathi said. And then we need to also think about how do we, as the government, how do we help governments think through what are the data standards that they want to build for their country? What are the common data that we should have available from everybody who's providing healthcare? And what is the data that a private sector company or any other provider of health services might keep as local data, right? So I don't think it's either I give all my data or I give none of my data, right? I think if we could find that middle ground in what data are useful. For example, chest x-rays, right? Chest x-rays where people have taken off their jewelry so that there are no identifying marks are incredibly important if we want to do digital AI-based radiography, you know, services in the future. Those images provided the patients at the time that the digital or the manual x-ray that can be converted to a film x-ray that can be converted to a digital x-ray, provided that that consent is given at the time, that can be an incredibly useful set of images that we can use to train software to recognize TB, to recognize COVID and other things, right? And that doesn't mean the private sector or any other health provider does so without the approval and without the consent of the patient, but it's also not identifying data, right? It's not personally identifying data. And maybe we limit, we say the only thing we will release about this person is whether it's male or female, right? Or the age group or something like that. So I think there's a middle ground where it's not none of my data, nor is it all of my data, because as consumers of health services, we, all of us around in this room today, would be uncomfortable if we knew that the government has said all health data are open data, right? Because we value privacy and consent. I don't want my employer to have access to my health insurance data, right? Because I feel that's private. But I recognize that in the aggregate level, an insurance company or a government can do a lot to try and figure out how is disease burden moving? How do I micro-target services? So I think it's this middle ground, this common sense middle ground that neither takes away competitive advantage nor hamstrings a government from using AI solutions. I think that's the middle ground. And I'm not saying we're there yet, because we're not, but I think that's what we should strive for.
I like this idea of this middle ground, but I think it comes back to something that was mentioned earlier in the discussion, that there's a level of education and capacity building that needs to happen in order for partners like governments to be able to work with others to find that middle ground. And so perhaps I can ask our brilliant panelists around this point around capacity building. You know, how have you been thinking about capacity building for governments, and what role do partners have to play, whether they are local partners on the ground or partners from high-income countries where there is where the majority of a lot of this AI, machine learning, data science knowledge exists to date? Maybe, Anne, I can start that question with you.
I was looking at Sati. Well, I think it's that we have a role. If this is the area that countries struggling with, and for advancing on its roadmap towards using AI in health, I think it's the role of donors or players in that country to also support that capacity building. I think the initiative the World Bank is taking, Marie-Lise, the digital leadership training. You do this together with Pat, I believe, and with other players. Correct. This is really a fantastic initiative, as you will be able to bring together decision makers from countries and help them understand it better. But I feel it's not only the health workforce or even the decision makers who need to have upskilled capabilities. It's kind of the population at large. Yeah. If you want to really tap into the potential of AI to improve population health, it may very well be that it will be much more individual. It will require more individual effort than from the health system only. And working on the different determinants may be much more efficient than working on the health system weaknesses. So I think it's for the whole population, it's necessary. And there's really brilliant initiatives going on, but on the ground in the countries, I feel it's part of the role of the partnership to evaluate, is this a priority for the country? Then we should find solutions. And I would be, as a potential donor, happy to support the training of people who need it for the decision making in that country to such a training you are offering, Marie-Lise.
Glad to hear, Anne.
Yeah.
And that segue of on the ground is the perfect segue to bring in Sati into the conversation. I know this topic of capacity building is something that you've thought quite a bit about, and I'm curious how you've been what learnings you might have from the capacity building approaches that you've taken within Jacaranda, as well as within kind of the region itself, that could help the audience as they're thinking about this topic of AI and global health.
Yeah, I mean, it's a tough one when you talk about machine learning and AI, because I think it's complex. It gets more complex every day. We won't even pretend as an organization that we understand everything that's going on under the hood. Maybe 5 people do. I would think there are probably 2 or 3 areas where capacity building can work. The first is, of course, government leadership capacity building. It's exciting to hear that there are so many initiatives underway. I do think the parallel is maybe when you talk about complex financial instruments in world markets, not everyone is going to understand that, but you need to have a core group of individuals who are, part of the equivalent of the consumer protection agency in a country who have the best interests of the citizens at heart. And it's incredibly important to have that in countries.
Yeah.
I also think that, I always reminded of a story where I was presenting how we triage and recognize danger signs. And one of the members of the audience, who's a lab analyst in one of the small clinics, came up and said, "Hey, I dabble in some of this stuff. I'd love to learn how you do this." I think it's important to recognize that we need to build the capacity across the board, not just in leadership levels. So more courses, more university programs that can support individuals, so that this is bread and butter. This is just what you learn, the same way you learn how to use Microsoft Word in a professional course. You need to understand some basic level of data and machine learning literacy. I think that's incredibly important. So those are the kind of two ends of the spectrum where you do need specialists, you do need expertise, and you do need sort of a basic level of literacy. And then bringing in, organizations like AI Kenya, for example, which is a grassroots, broad partnership that brings a bunch of people together that can serve as a trusted advisor in some of these things. No incentive, no sort of vested interest, but a body that can be a third party to vet some of the solutions that come into play.
Makes sense. I know we're quickly running out of time, so maybe the last question I'd like to pose to each of you goes back to the theme of today's discussion, which is all around partnerships. Many members of the audience are probably very eager to establish partnerships with leading organizations like Novartis Foundation, World Bank, Jacaranda. And while no sector is homogeneous, what advice would you have to those who seek partnerships with those sectors, the private sector, donors, and NGOs, to support their work in AI and global health, or perhaps digital health more broadly? And maybe, Marlies, I can start with you.
Thanks very much, Natasha. First, to say that 2 points I'd like to make. First, that we welcome partners, and I think we recognize that we are all learning about how to do partnership together. Because when it comes to digital health and AI and using Uber Eats to deliver medicine prescriptions, there are so many technologies and tools that are out there. But we're all learning about how to do partnerships well, right? So I think coming with a sense of we have a solution, but we're also keen to understand how things work. I think that is critically important. Linked to that is, we often find that when we engage, particularly with the private sector, who may have an excellent solution, but have not yet applied it in a low and middle income country, that an initial engagement that focuses on understanding how the health system works is very effective. We have partnerships, for example, with Google, with Microsoft, with others, that provide data scientists to the World Bank on a pro bono basis for a period of time, right? And we've learned initially these partnerships, these pro bono provision of services was like a secondment for 3 months. And then we learned that it takes 3 months just to understand how low and middle income country health systems begin to work, right? Then we said 6 months. I think now we've said, hang on, it's probably going to take a year, because we're going to spend 3 months learning, 6 months finding the data, and then 3 months building the algorithm, right? And my first time I got involved in a machine learning assignment, I was so disappointed at how easy it is to build an algorithm, right? And that we spent all our time in getting and cleaning data. And I think that's still the case. So I think there are lots of opportunities, but I think we need to figure out what are the quick wins. We need to make sure that the technology companies understand the context, and that on the government and NGO sector side, we understand what the technology can and cannot do, right? That the technology will always be subservient to the problem we're trying to solve. And I think if we can do that, we have seen successful partnerships. Our data collaboratives effort, other efforts, there are examples where this is being done well, and I think we can do so well. But I think we have to approach this with a sense of humility, and let's all figure this out together, because we've not done this. This is pioneering work, exciting but pioneering work, and we're going to have to jointly trust each other and jointly move forward. Thank you.
Great points, Marlies. Maybe final thoughts from yourself, Sathi?
I can give the perspective of anyone who's a relatively small innovator in the crowd. I think if you're solving a problem, both Anne and Marlies mentioned this, that's critical. If you have a problem of scale, that's when you can bring partners to the table, whether it's technology partners, funders, donors. It should not be about solution. It should not be like, how can I use AI to solve a problem? It should be, here's a problem of scale. This is ideal for machine learning. And I think, at least in our experience, we've found that very useful and a very successful approach, both for benefiting people, but also for, raising funding, building partnerships, et cetera.
I love that you brought it back to this needs-based approach. And final thoughts?
Oh, I wanted to say exactly the same thing. So no need for time, but needs-driven, it has to be needs-driven. And the proposal has to include an understanding of the local context. And then it has to be human-centered, so the same points I made in the beginning. And it has to be, for us at the Novartis Foundation, we look for proven solutions, that they have been applied somewhere already, that we don't have to validate from scratch.
Makes sense. Thank you so much. I think hopefully to the audience, you've really picked up on this point that strong partnerships and stakeholder engagements are really going to fuel AI innovation and positive health impact. And we do need a wide network of experts from the private sector, the public sector, academia, civil society. All of them are needed to create these goal-oriented, needs-based partnerships that are going to be critical to our success in AI and global health. So thank you, Anne. Thank you, Sathi. Thank you, Marlies, for your fantastic thoughts and contributions in today's discussion. Have a great day to everyone on the call, and thank you again for joining.
Thank you, Natasha, and thank you. It was nice to be here. Bye.
Bye-bye.
Bye-bye, everyone.